Presentation is entitled Modified Blumgart Pancreaticojejunostomy with External Stenting and Laparoscopic Whipple Reconstruction. Here we present the case of a 60-year-old man who was found to have a 3-centimeter periampullary mass. His past medical history is notable for a BMI of 35 and a background of GERD and obstructive sleep apnea. Staging CT scans showed no evidence of metastatic disease. The patient was discussed in our pancreatic multidisciplinary tumor board, and a Whipple procedure was suggested. The resection phase was uneventful and was omitted for this presentation. As can be appreciated, the consistency of the gland is very soft, and the pancreatic duct measures 2 millimeters. A stitch was placed into the anterior surface of the pancreatic duct to facilitate identification and enable gentle manipulation. We start the outer layer using a 2-0 polyester suture that had been previously shortened and tied together, creating a total length of 24 to 30 centimeters. The suture begins from each arm in the antimesenteric aspect of the jejunum and passes through the entire thickness of the pancreatic gland. Bulldog clamps were placed on each pair of strands for retraction. Usually, 3 transpancreatic sutures are required along the length of the pancreatico-jejunal anastomosis. We check the suture and the posterior outer layers are correctly aligned. We proceed to perform the enterotomy in the antimesenteric aspect of the jejunum, matching the size and location of the pancreatic duct. A second enterotomy was made through the blind end of the biliopancreatic limb using a Maryland dissector, and then the Maryland is used to pass a silastic feeding tube through the enterotomy facing the pancreatic duct. We pass the distal stent out of the abdomen. The inner layer is performed with 2 4-0 PDS sutures in a running fashion and incorporates the pancreatic duct and the jejunal mucosa. The suture is left untied. We then insert the stent into the pancreatic duct and start sewing the anterior layer with a new 4-0 PDS single-arm suture in a continuous fashion. Once completed, the 2 sutures of the inner layer are tied. Finally, we complete our transpancreatic outer layer, passing all of the 2-0 polyester sutures through the outer layer of the front wall, tightening the anastomosis first and then tying them one by one. We use a polygalactin suture to secure the jejunal exit of the pancreatic stent. Although in this case we sewed the stent into the bowel, we usually do the same thing with the anastomosis as well. The total duration of the surgery was 6 hours. The patient had no other intraoperative complications and was extubated in the OR. 2 closed suction drains were left behind, and the patient received 72 hours of intravenous steroids with the first dose administered intraoperatively. Post-op drain fluid amylase on day 1 was 1,400 and 100 micromoles per liter and was normalized by day 3, at which point the drains were removed. No post-operative complications were observed, and the total length of stay in hospital was 4 days. Pathologic analysis of the specimen showed periampullary tubulovillous adenoma with high-grade dysplasia. No invasive carcinoma was observed in the specimen. We pulled out the pancreatic stent within the 3rd week of the post-operative period. At 4 months post-op, the patient had continued to recover uneventfully.